So, good afternoon, everyone. It's been a really fun couple of hours already, and we'll try to fill your minds with DC policy for the next hour. So this is, in fact, a cancer policy in 2020 session, but we immediately have to move from cancer policy to the pandemic. Because everything that is happening in cancer policy is affected by the pandemic. And so the beginning of this presentation will be pandemic heavy, as it absolutely must be. So many days, Shelley, Lindsay, and I get together and talk about the numbers. And we do that to remind ourselves where the pandemic is. And Lindsay, you're going to give me the next slide. We talk about the numbers to give ourselves, as I said, a sense of where this pandemic is, what it means for cancer patients, and what it means for the policy work we're trying to do for people with cancer. So we developed this slide last Thursday, June 11th. And we decided we'd leave it at June 11 numbers and update you today because it's a way of really conveying the very tragic dynamism of this pandemic. So when we prepared this, there were a little over 2 million cases of COVID-19 in the US, and there are many tens of thousands more. When we prepared this, there were 112 recorded deaths from COVID-19 in the US. You know, most experts believe that our reporting is woefully inadequate and that number is an underrepresentation. But even accepting it, there are now more than 116,000 deaths from COVID. So since June 11th, worldwide, 7.5 million cases. And since June 11th, the number of deaths has increased to 430,000. Although, and I think the map is a little bit obscured, but although the course of the pandemic, the curve has been bent in a number of states that were initially hard hit, like New York, New Jersey. There are today, on Monday, there are 19 states where the number of cases are still increasing, and that's number of cases, and in most states, it's also an increase in the number of hospitalizations and an increase in the number of deaths. So the discussion over the weekend was, are we in a second wave of the COVID-19 pandemic? No, the experts say we are still very much in the first wave. Hold on to your hats. The second wave will be in the fall. So these are big numbers, big impact on Americans, big impact on cancer patients. And I know that probably don't need to tell you these tragic numbers. Since mid-March, more than 44 million people have applied for unemployment. And in the week of May 30th, almost 21 million individuals, Americans, were receiving unemployment. The difference there is, you know, the full course of the pandemic versus that 1 week. So
Elizabeth, I just want to say something. Someone is asking what the colors on the map mean.
Okay, so you see the dark blue. The dark blue are the states that are experiencing significant increases in cases. I think, although this is how dynamic the situation is, I'm straining to look at this. These colors aren't even accurate as of from yesterday to today when Shelley added them, because now Arkansas and Mississippi would be the dark color because there's been a really significant surge in cases there. So basically already out of date, but the dark blue indicates states where the increase in cases is significant.
Thanks for clarifying that.
Yep. So let's go to the next slide and talk about the impact of the pandemic on cancer survivors. So why the heck is the pandemic having such a significant effect on people with cancer? Well, it's really two reasons. One, the special vulnerability of people with cancer to COVID, which we now understand from some research and published papers. And second, when the rules of social distancing went into effect by action of states or by voluntary action in certain other states, those standards, to try to bend the curve of the pandemic, immediately caused there to be disruptions in cancer care. And the cancer providers had to consider, in a situation where the rule to try to address the pandemic was to socially distance, how in the heck they could protect themselves, their staff, most importantly, their patients and their patients' families, and still provide them cancer care. So, decisions were made early on, by mid-March, sometimes by states, sometimes by institutions, sometimes by individual practices, to delay a lot of care. If anything was considered elective, sometimes there were public health rules that those things couldn't be done, or providers decide themselves. And so a lot of cancer care got classified as elective and therefore delayed. And then practices also had to think long and hard about ways that they could be safe, even for things that were not elective. And that meant obtaining enough personal protective equipment for themselves, for patients, making sure that the physical layout of their offices was appropriate for, distance, and also just things like their scheduling, how they let people in the office, all of those things they had to think through. And, a lot of practices have now done that. One of the biggest changes that has happened in cancer care, and we heard a lot about that this morning from people who've already gone through telehealth services, is that office visits that don't require a procedure have been shifted dramatically to telehealth. So people are receiving their care via telehealth service at home. And that is possible because of changes, first, that the Congress triggered, and then that the Centers for Medicare and Medicaid Services further defined for Medicare, and private payers have defined for their own patients, so that providers can be paid for these telehealth services that don't meet the historic standards for telehealth. I'm gonna finish a little bit and more of this, and then let Shelley talk a lot about the telehealth project that NCCS is undertaking and actually wrapping up really, really soon. Really very early in the COVID pandemic, NCCS sponsored a webinar with Dr. Otis Brawley of Johns Hopkins Cancer Center. And at that time, Dr. Brawley said, "I'm going to tell you what I think we should do for cancer patients, but I'm doing that without data." And he said, we think early epidemic that that cancer patients who are immune compromised, if they are in treatment, just finishing treatment, certain other individuals who remain immunocompromised, that they are at heightened risk of COVID. Special steps need to be taken to be sure that they are protected from COVID, and also difficult decisions need to be made about any additional treatment. Since then, Dr. Brawley has made some additional guest appearances to share with us the research that does in fact confirm the special risk of people with cancer, and also the sad news out of China and also the US that people with cancer who do contract COVID-19 are having worse outcomes. They seem especially vulnerable not only to contracting, but to having a worse outcome. And of course, I know that some of you have already spoken to this earlier today. There is this other impact of COVID-19, which is not about your healthcare, but about directly, but about your loss of job loss of insurance that then, of course, threatens your future access to care. You know, in that 44 million number are included lots of people with cancer who are struggling. And we are hearing every single day from cancer survivors about the worry that relates to their loss of job, loss of insurance, potential loss of care, as well as just the day-to-day worry about their exposure to and vulnerability to COVID. Let's go to the next slide. I'll talk a little bit more, and then Shelley, would you be willing to talk about the telehealth project? Let me do this first part of this about some additional impacts of COVID on cancer care. The electronic health records vendor Epic reported just a couple of months ago, so pretty early in the pandemic, that claims for screening and preventive services really across the board, but especially extreme for cancer screening, that the claims had just fallen through the floor. So we're really not doing much mammography, not much screening for colon cancer, all of the screening for colon cancer, including colonoscopy, and no, and very little prostate cancer screening. So there are currently, now that we have sort of worked through some of the issues of distancing in the healthcare setting, there are some efforts to resume screening programs, but there is very profound concern among professional societies who've been looking at the gaps in screening and predicting disturbing numbers for 2021 and 2022 even, fears that all of those cancers are, and especially colon cancer. I don't know if it's especially colon cancer or there's an especially good projection about colon cancer, but real fears that in the years to come, we're going to be looking at diagnosis, later stage diagnoses of those cancers. Again, as I've said, you know, there has been, thanks to regulatory and legislative changes that have been made, there's been this shift of site for cancer care to the telehealth service, so the ability for the patient to receive care at home. That's been identified by people as maybe a change that should be fostered and should last past the COVID pandemic. And to that point, NCCS has been in the middle of a really exciting study to find out what cancer patients think about telehealth, and how, if telehealth is to be a standard for cancer care going forward, how we ensure that that care provided by telehealth is quality care. So Shelley, will you tell people what we're doing and how we're trying to do that sort of assessment?
Sure. So as Elizabeth mentioned, we just wanted to make sure that we were bringing the patient voice and the patient perspective to telehealth. Obviously, I've heard people say, you know, we're doing 10 years of innovation in healthcare in a matter of months because of necessity, because of the pandemic. And so with reimbursement changes that allow for reimbursement for telehealth and the need for telehealth to keep people at home, everything moved rapidly to implement this and no one was really asking patients, what do they think? And how do we make this most effective for them? So we convened a steering committee of 8 cancer patients and survivors who would help guide us in the process of getting input from cancer patients. And then they went out and recruited people to participate in focus groups. We completed 6 focus groups. Most of them were teleconference or video conference, but one we did just phone only. We try to get a diversity of perspectives, different parts of the country, people who live in rural areas, people who live in urban areas, people who are in treatment, who've completed treatment, different types of cancer, stage of disease, racial and ethnic backgrounds, and really try to understand what their experience is, what are the barriers they face, how can we try to overcome those barriers, when are telehealth visits effective, when are they not the best approach, and what can patients do to help prepare for an effective telehealth visit. And so we are compiling those results. We're going to actually present it during a breakout session next week, the initial findings, what we heard from the focus group participants, And then the next steps in the project are to get additional feedback from our steering committee. We're also going to get feedback from providers on their experience, and also what we heard from their feedback on what we heard from patients. And our goal is to produce a resource for providers to help overcome barriers to telehealth, a resource for patients to prepare for those visits, and then a policy white paper with recommendations from a policy perspective. A lot of this does hinge on reimbursement. The reimbursement changes that have been made that helped facilitate this were considered temporary. It seems as though the cat's out of the bag, and we're never going to go back to, well, we might not go back to where we were, but if reimbursement changes aren't made more long-term, then it may not be an option for patients when, for a lot of the types of visits we heard from people that it was really effective, some of the follow-up visits where a physical exam is not needed, it saves people a lot of time, a lot of travel, a lot of effort to do a telehealth visit. But if reimbursement doesn't continue, then providers may not offer it as an option. So that's where I think some of the policy recommendations will come in. So we are in progress on this project, but we wanted to at least report to you all where we are so far and what we've heard. And that's what we'll do in more detail next week in the breakout session that we have. And Chris McNiff, who's been working with us on this project, is going to help present. She's compiling the results from the themes that we heard during the focus groups right now, and we'll be able to give you guys a first look at that next week when we have that session.
Yeah, and I don't want to really preview too much of what Chris is going to say, but there's some really fascinating questions that arise in telehealth, like, you know, how could we define a multidisciplinary telehealth visit, and then how might it be properly reimbursed? There's a lot of discussion about, you know, how can you do monitoring via telehealth, and what sort of wearables or other equipment might be necessary? How do we pay for them? How do we make sure they're used properly by patients and providers together? And then there's a lot of discussion about the role of the caregiver in the telehealth visit, and, you know, sort of how to train them and engage them and have them as almost part of the team for telehealth. So some fascinating questions about how cancer care might be provided in the future. Sad that it was triggered by the pandemic, but potentially some interesting opportunities. So what we've talked about so far, we've really been focusing on what these changes mean for the cancer patient. That's what we should be doing. We should be thinking about you guys and what the pandemic has meant. But let's pause for a minute and think about what it's meant for the provider. So what it has meant for the provider is, you know, just like for many of us, when the economy shut down, their practices shut down. And, you know, they embrace telehealth as a way to, you know, care for people, and a way to keep their practices vibrant, and a way to maintain continuity of care. But overall, you know, the providers really suffered a very significant shock to the system when everything shut down. We're going to talk in a minute about how Congress responded to that and some of the controversy around that. We at NCCS stay in very close touch with all the cancer care professional societies, and really what they are doing almost day to day, certainly week to week, so that their practices are prepared to adjust to and provide care during the pandemic. And those groups, ASCO, ASTRO, pathology groups, tell us that they have made very significant adjustments to practice, and, you know, are able to see most of you. There are still delays in care, but combining telehealth and improvements in how they see people in their offices, much more care is underway than was early in the pandemic. However, there are still going to be some lasting impacts of how we've rethought things. Lots of people think there's going to be consolidation of healthcare systems, so practices combining, hospital systems combining, other health systems combining, and, you know, that's going to raise questions going forward for geographic gaps in care, or, you know, cost of care. Sometimes consolidation results in higher cost of care, not lower. And then there's also, just because we've been doing less during the pandemic, it's really caused a reconsideration of a fundamental assumption of the American healthcare system, which is that we pay based on procedure or volume. And when the provider can't provide all of the services they have historically, it really turns the system of payment on its head. And some of the people that you are going to hear from tomorrow, some of the health professionals, I think are going to address this, but some experts believe that this is not a bad thing if we can get through the transition, that maybe moving away from a volume-based system of care to a more episodic or bundled system of care that is better coordinated may be better in the long run. It won't be done easily. It won't be done with a lot of bumps along the road, but I think you'll get some insights tomorrow from professionals about some ways that that might happen and how that could be a positive for the system. Let's go to the next slide. So everyone has been calling this a pandemic within a pandemic, and we're sort of calling it a pandemic within a pandemic within a pandemic, sort of endlessly, because there are so many epidemics going at once when you talk about the population of cancer survivors. First of all, you guys know that African Americans are at a much heightened risk of COVID-19, and that is both in risk of contracting the disease and also worse outcomes. I know that our audience is spread across the country, but those of us in DC are watching the numbers, and they're very scary for the disproportionate impact of COVID-19 on African Americans in the Metro DC area. There is also a less disproportionate but very serious impact on the Hispanic population in the DC area. And both of those groups are having worse outcomes from COVID-19, and that is generally borne out across the country. And this is not news to this community, to all of us, because there has historically been disparities in access to cancer care for African Americans. We've been heartened by the fact that the Affordable Care Act seems to have begun in a minor way to address some of the issues of access to insurance, so that African Americans who have historically received care later and after diagnosis have suffered delays in care, that the Affordable Care Act, which provides access to insurance through the exchanges, and also the Medicaid expansion, also authorized by the Affordable Care Act, has begun to address some of those insurance access issues and delays in care. And thanks to the data collection and analysis by the American Cancer Society, there have been a couple of good papers in the last few months noting that improvement in access to insurance. Tragically, the COVID epidemic, with loss of employment, with some of the states backing away from Medicaid, we fear that some of that progress could be turned back, and that's one of the things we've been really pressing Congress about. Let's go to the next slide. So where the heck is the Congress? Well, the Congress has, as you know, thrown a lot of money at COVID. As a general matter, congressional Democrats have pressed for improvements in preparedness and pressed for lots of stimulus money and unemployment dollars and paid leave dollars. And ultimately, the first three responses from the Congress, the Coronavirus Preparedness and Response Supplemental Appropriations Act, signed into law early in March, the Families First Coronavirus Response Act, signed into law just a couple of weeks after that, and then the CARES Act, signed into law at the end of March. All three of those were ultimately bipartisan packages, very large, price tags always in the trillions. The most recent effort, the HEROES Act, and we're going to go over all of these, has been approved by the House, but has been declared dead on arrival by the Senate Republican leadership. And so we are at stasis. We are stalled on what will happen next in responding to coronavirus. The Senate Republican leadership has indicated that they were heartened by the improvement in the unemployment rate of for May, and they would like to see the impact of the stimulus that's out there now before taking act on the HEROES Act or anything like it, and they have suggested they won't do that until the end of July. But let's talk specifically about the bills that have happened, because it's important to look at them and see how Congress is responding to the needs of Americans, and then we'll talk about the gaps that still exist. So the Coronavirus Preparedness Act was, it's money. It's supplemental appropriations. It was approved very early in the pandemic at the beginning of March, and it was an effort to get some money in the system, into the public health system, essentially, to try to make up for some lost time in terms of the preparedness for the pandemic. So the biggest chunk of funds went to the Food and Drug Administration, the Centers for Disease Control and Prevention, the National Institutes of Health, and other agencies like FEMA even, who are engaged in the pandemic effort. It was at about this time, as Shelley's photo shows, that the Coronavirus Task Force was convened, and we have there Dr. Fauci and Dr. Birx. So this money came into the system at the time the task force was convening and beginning to do planning and pandemic response. Also in this early piece of legislation, which happened, I'm not kidding, in a matter of a couple of days, because the situation is considered that dire, included was this first step in eliminating the restrictions in Medicare for telehealth services. That statutory action was then built on by the Trump administration to provide additional flexibilities, but Congress got that going with the recognition that we needed to find a way for provision of care through telehealth. Let's go to the next slide. So less than 2 weeks later, the Congress approved the Families First Act, and this included additional preparedness dollars, but this was really the first time that Congress woke up and said, we got a lot of people suffering. We got kids who are out of school, most schools closed, and they're not getting school lunches, school breakfast. We gotta get them some food. We gotta get unemployment benefits authorized, and we need paid leave. There also was an effort to provide payment in addition to insurance, anything having to do with health insurance access, just money available for COVID-19 treatment, especially to address cost sharing. So this was a controversial package because the unemployment benefits, these are federal dollars, but the unemployment benefits were, what do they call it? They were upped. They were plussed up. I think that's what Larry Kudlow says. So there's an additional $600 a month of benefit. So it's a more generous unemployment benefit than typically paid. And there was a lot of resistance to that from especially Republican Senators Tim Scott and Lindsey Graham, who said that it read to them as an incentive not to work. So this was controversial, but ultimately was passed and signed into law. And sadly, as you may know, some people who should be eligible for unemployment through this package have still not gotten their benefits because the system has been so overwhelmed. I want to just note this emergency and limited paid leave program. This package, as I told you, was approved toward the middle of March, and we thought that, you know, quarantining for 2 weeks was it. You know, we still were young and naive, and we thought that we were going to solve a lot of these issues by keeping people quarantined for a couple of weeks. And so this paid leave program was essentially a 2-week paid leave program. If you yourself had been exposed to COVID and you needed to go into 2-week quarantine, you could tap into this paid leave program. If you were a caregiver for someone with COVID-19, you could tap into this paid leave program, but it was limited in duration and limited in its benefit for 2 weeks. And so we're gonna come back to that because we are sadly finding out that is just not adequate, and certainly not adequate for cancer survivors. Let's go to the next slide. So the CARES Act is, I think, just a continuation of the Families First Act. It was passed literally 9 days after and enacted into and signed into law. And this is the act that actually authorized the stimulus checks that many Americans got. It made some modifications in the unemployment program of the Families First Act. It provided a paycheck protection program, which is assistance to small businesses and nonprofits to help them retain their employees. And it is essentially a forgivable loan program, so it turns into a grant if grantees meet the standard of retaining employees. The program has since been expanded and tweaked, and there is even some suggestion it will be tweaked again for people to apply for a second round of paycheck protection assistance. The Democrats in Congress forced testing dollars on the Trump administration. This was ultimately passed in bipartisan fashion. I don't think the testing dollars have been fully utilized by the Trump administration because, as you know, they believe that testing should still be primarily a state responsibility. The CARES Act also included substantial dollars for healthcare providers affected by COVID-19. So we already talked about the oncology provider who would be affected by COVID-19 by being forced to change practice standards, purchase more personal protective equipment. Maybe they were closed for some period of time while they figured all of that out. So there's those effects. The other effects of COVID-19 are obviously the New York and New Jersey and Seattle and Los Angeles hospitals who were overwhelmed by COVID-19 patients. They certainly need assistance. There are also lots of hospitals where that depend on elective surgeries. Many of the children's hospitals across the country, their census is down dramatically. At some institutions, down by 70% because parents don't want to do anything that is at all elective in this climate. So there are providers who are suffering greatly because they have no patience. And so Congress provided big chunks of financial assistance to institutions. This has become a very controversial program. The dollars have been delivered in the first instance. There's still money to go out, but the dollars have been provided on the basis of institutions' Medicare billing. So that means that it has no direct relationship to the COVID burden, and it has no direct relationship, for example, for those children's hospitals that are suffering because of COVID, because they're not Medicare billers. So it's been controversial in that way, and it has been controversial because some major systems, including, according to the New York Times, HCA Healthcare, received about $1 billion, and they nonetheless made very, very significant reductions in their healthcare staffing because of COVID, even with $1 billion grant. So this is a very controversial program. People do not feel that it has been directed necessarily to the right institution. So stay tuned. I think that the money is out the door. I don't know if Congress will try to fix it or try to direct resources to additional institutions that didn't get assistance. And then finally, the CARES Act tried to address the shortages in medical supplies. You may remember, if you're a news watcher, for weeks we talked about the fact that we couldn't do testing because we didn't have swabs. So this CARES Act was intended to address that and also put a lot of money into what's now called Operation Warp Speed to speed up the development of COVID-19 therapies and vaccines. Let's go to the next slide and then do some questions. So the next slide is about the HEROES Act, which has been passed by the House of Representatives on a party line vote, a fairly narrow vote. And this act is most controversial because it includes assistance to states and localities. Lindsay, can you shift the slide? So the most controversial issue, the thing that has Democrats and Republicans at loggerheads, is the assistance to states and localities. You have probably seen a tweet from President Trump saying he will not give a Democrat city any assistance. But you know, there are also, so that's the main point of contention, but there are also disagreements about whether we need to do another stimulus payment. Economic advisor Larry Kudlow said yesterday that the White House might be willing to see unemployment benefits extended beyond end of July, but not with the plus up of the $600 a month. We are big supporters of the paid leave program, which is included in the House passed bill. This would provide federally funded paid leave for people who are especially vulnerable to COVID, who are at risk if they are forced to go back to work, especially in frontline jobs. We have heard in the last few weeks from lots of cancer survivors, some in active treatment, who don't believe that it is safe for them to return to work, but their employers are saying it's take it or leave it, and there's not a stay at home or work from home possibility for them. So the paid leave program that is included in the House bill would address that. There would be a necessity for an individual to have some certification of their special need, of their vulnerability because of COVID, before they could apply for the paid leave program, but that is generously funded in the House bill, and the Senate has signaled resistance to that at the current time. So right now, as I said earlier, Senate Republicans are saying they will be willing to come to the table to negotiate some sort of fourth package, but not until the end of July. I think President Trump is anxious to do it sooner, because this weekend, another of his economic advisors, Peter Navarro, said that the president was willing to do another fourth relief package, that he would be willing to agree to some variety of provisions, adding up to a $2 trillion package, so a fairly substantial amount. So I think that is a suggestion that the president and Senate Republicans may be, at least on this day, at a slightly different position. So we are anxious to see some negotiation on the HEROES Act because of the paid leave program, because we know there are lots of cancer survivors whose unemployment benefits are soon to run out. So we hope that some negotiation begins on that soon. And last slide. So we really talked about this. I mean, the challenges for the cancer survivor are still really great. Even if the system, the healthcare system, has made some important adjustments so that more of you are able to get your care safely through telehealth, through reconsidered office visits, through very safe infusion sites for your chemotherapy, there's still real challenges for people with cancer. There's the issue, as we just talked about, of that person who is immune compromised and really cannot easily go back to her frontline job, especially with the COVID cases increasing in so many locales and with so much COVID in circulation. As we have talked about, there is still, for the cancer survivor, the heightened risk of contracting COVID and a worse outcome if diagnosed. We are actually optimistic, but think there will be bumps along the way as we move, be it a year or 2 years through the COVID pandemic, and look at how cancer care looks on the other side. We actually, as Shelley said, through telehealth and other things, we feel some optimism about how things may evolve, but it's going to be a bumpy road to get there. And finally, we have been hearing from all of you about issues of availability of mental health services during the pandemic, as we all deal with the stress of living through the pandemic, living through cancer treatment and survivorship. So, and that is an issue that I know policymakers talk about a lot, but they really have not thought seriously about how to address that and improve access. Lindsay, Shelley, what else do we want to say, and do we want to open to questions?
Yeah, this is Shelley. So we, first of all, if you have questions, type them in the chat box. We've got a couple questions, and so I will start by, this is a question from Mark, and I think I can start answering and then you can chime in. Okay. Can something be done to expand general awareness that vulnerable people are not limited to nursing home residents or more generally the elderly? That is something that we are definitely working on. It'll be part of what we talk about next week in our Hill visits. And so when we, as we know, the data on COVID-19 is evolving over time. And when we had Dr. Brawley for our first webinar that we did early April, he said, he always likes to say, here's what I know and here's what I believe. And he's had fundamental concerns about people in treatment or people who are recently completed with treatment working in environments where they were going to be around people and potentially exposed, but he didn't have data to support that. Well, since then, there has been more data to support not just people who have cancer, but people who are cancer survivors who've had chemotherapy. And he actually presented at a Hill briefing a few weeks ago, because there are some groups, and we're part of that are working together to try to expand these paid leave provisions. And one of the groups that's really leading the charge in this is the Cystic Fibrosis patient, because again, Cystic Fibrosis Foundation, because their patients are vulnerable and they're not necessarily nursing home residents or the elderly. So I think that there is definitely effort being made, at least to educate members of Congress and their staff about what does vulnerable people mean, and that is definitely going to be part of what we're going to be working on next week with our virtual Hill visits. Elizabeth, Lindsay, do you want to add anything?
Yeah, you got it. I think I got to be honest. It's a steep learning curve. I mean, we have a lot of work to do to educate members of Congress about this, because the administration has not, as one of our earlier speakers, Caitlin, said, the information about and the communication of information about this disease has been uneven at the very best. And so there's so many gaps in public understanding and policymaker understanding of the disease. And there are also just things we don't know. So we are trying really hard, to be educators to policymakers about what it is to be vulnerable to COVID-19. In terms of the legislation, the way that we were able to, persuade the House to do it, and by legislation, I mean the provision of paid leave to people who really are vulnerable and shouldn't be back at a frontline job or, at risk. it is essentially a medical certification that they should not be back in the workplace. So that's how the House was willing to address that issue. But we do face a very steep burden in trying to educate senators about this. They have been resistant, think that we just need to get back to work. And so we do have a lot of work to do on that.
Another question is, and I addressed it a little bit, but I wanted to say a little bit more, is a cancer survivor at risk of worse outcomes of contracting the coronavirus related to a weakened immune system or other issues? So I talked about Dr. Brawley talking about the evolving evidence on the impact of, or the outcomes for cancer survivors who contract COVID-19. We did a webinar last month. I'm going to say last month because I don't remember the day and everything runs together, but I think it was in May, with radiation oncologists in partnership with Astro. And they said that radiation treatment alone does not make someone immune compromised. Now, we know obviously that many cancer survivors have a combination of radiation therapy and other therapies. So they were speaking solely to radiation therapy alone, that it does not compromise the immune system. I think this is a question I'm going to pose tomorrow to our panel of experts. We have 4 medical oncologists including Dr. Brawley, who's joining us again. Every time I listen to Dr. Brawley, I learn more because he's keeping up with, the data that as we learn it. And so I think what we hear from him tomorrow will be different from what we heard from him in April. I think we can ask him more about this. Elizabeth, were you going to add something as well?
I was going to say that I think there are 2 papers that are peer-reviewed on this issue of the risk of cancer patients. I think they're all open access. So why don't we, can we post them? They're open access, so we can put them on the website or wherever, so people can see them, because it's not, things are moving so fast, but these are good peer-reviewed papers. We can get them to you so you can see what the literature says about the risks to cancer patients or cancer survivors.
Okay, Jennifer asked a question that I don't have an answer to, but maybe you all can help with. How about cancer patients who are students? Are these patients at greater risk as universities, colleges, and schools open? Could this be a reason to advocate for synchronous classes for this group? I don't really have a good answer to that, but I would pose that in case you all do.
I think that's a really wonderful question for Dr. Brawley, because I don't think there is literature. I don't think there is, but he would be willing to answer, here's what I know and here's what I think.
Mm-hmm.
And I think that could inform what we should be saying to colleges and universities and schools about cancer survivors. There's also a paper on children with cancer and COVID, and it was, I think it was slightly more encouraging than the adults with cancer trends, but we'll make that available to you as well. But I think we should ask Dr. Brawley that question.
Well, and we saw that, some of the universities are planning to bring students back and then have a shortened semester and get people out of there by around Thanksgiving, assuming or predicting that there'll be that spike in the fall. I wonder if the fact that cases are rising in so many states now will change their calculus when they're thinking about bringing students back. And I know that, I think obviously that's for universities, and then for elementary through high school, I think there's a lot of uncertainty about what will happen next year for sure.
And I would raise another issue related to the schools. I know some teacher association and unions have been raising issues about the safety of teachers, and we need to think about cancer survivors who are teachers.
Exactly.
And what, I think that would bring up especially the paid leave program, but we need to think about that, and maybe that's another question, if not tomorrow, to pose sometime too soon to our experts.
And I know last week when I was at the Stupid CancerCon event, I think this issue was brought up, and I don't have any additional insights on this, but that someone mentioned that it would be important to advocate for yourself to have a disability counselor, and that those are often positions at institutions of higher learning. And so that's another way to be heard and maybe have some adjustments made for your schedule.
I know some organizations have been suggesting to the cancer survivors they serve that they make a first, second, and third plea to their employers about accommodation to let them work at home. And I've heard that, you know, that there's been some mixed success. I know that we've gotten feedback from cancer survivors who are not having the greatest success with that if their job is sort of a frontline one that cannot easily be done work from home.
I don't see any other questions. Does anybody else have a question?
I have a question.
Okay.
One that I was
supposed to have the answers.
I mean, I was going to say, I was like, I mean, I don't think anybody really knows the answer to this, but I think we can kind of brainstorm possibilities. So, I mean, with the packages going boom, 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 passing up front because there was just this collective urgency, and, you know, back in March and early April, things were very different than they are now. It seems like, especially, things are more politicized. It's going to get tougher for another package to get passed. The Senate has said, like you mentioned, that this next package dead on arrival. So, I mean, how do we advocate at this point if things are kind of stalling, and where do we go from here? Elizabeth, tell us, please. Where do we go from here?
You know, the reason that we felt we had to talk a lot about COVID is because it's what frames this. I mean, and COVID is not gone. And so the threats associated with it, you know, to health, to employment, et cetera, are still there. And I think, although, you know, the White House is really just moving on past COVID and pretending, I don't believe that is true of, you know, Republican members of Congress. They wish it were so, but I don't think they're as bought in. So I just think we have to be, I mean, we have to be aggressive about what it's still like out here. And COVID is not gone, and the risks associated with it are not gone, and the disruptions to our society are not gone, healthcare, employment, et cetera.
So I want to bring up this question that CJ posed. When talking about survivors being more vulnerable, vulnerable, are you referring to a survivor at any point along the diagnosis to death continuum, which could be decades? I think that's a big part of the problem is you don't know. We don't know how long someone is compromised. And we also have to take into account how someone feels and what their concerns about their own risk are and their own comfort level. But then it's hard to then put that into a policy. And I think, you know, when you talk about, like, one option for somebody could be disability, but then you have to get a medical provider to say that you have a qualifying condition, and fear is not necessarily a qualifying condition. So I think that part of the problem is there isn't great data, and we don't know, and yet people have these fears that make them not feel comfortable going back to work or wanting some kind of accommodations at work to reduce their risk.
So we'll ask this question. We keep quoting Dr. Brawley in absentia. We'll ask him again. I mean, I don't want to characterize too much what he said, but, you know, early on he said, look, we don't know if the very far out survivor, you know, 20 years into survivorship, probably not, you know, immune compromised and probably not at risk. And we don't know about others. And now we do know a little bit about, you know, people who are immune compromised, who are in treatment, and about their outcomes. And so we do know a little bit, but we have gaps in our knowledge. The reason it's worth asking Dr. Brawley again is because more has happened and we know more about the disease of COVID and the interaction with cancer. And also, I sense from him a greater concern, and so a willingness to be slightly more aggressive about the risks to people with cancer in the absence of data. So let's tease it out again with him tomorrow.
And we need to head back to the main session, but I want to, Caroline asked a question about employers balking about high healthcare expenses and discrimination, and I want to suggest that you bring that up in the work and cancer session, which will be tomorrow breakout at 1:30, because I think our expert there will be able to talk about it as well. So now I think we need.
Okay, can I do one? Can I have 1 minute?
Mm-hmm.
Here's an issue for the future, guys. We need. There's a lot of sense that cancer survivors, maybe all cancer survivors, certainly a lot of cancer survivors, probably be among the first recipients of vaccine, of a COVID vaccine. They need protection, et cetera. We need to stay on top of this issue of the development and proper regulatory review of vaccine, because if cancer survivors need a COVID vaccine, they need one that is safe and effective. And there's a lot of political pressure around the fast part of the COVID vaccine, and we need to be sure that it's not only done rapidly, but that it is in fact, or multiple safe and effective vaccines. So there's a policy issue we all are going to need to stay on top of as we move forward.
Great. Thank you so much, Elizabeth and Lindsay. And now we're going to go back to the main session for a few concluding remarks. Thank you.